This is Chapter 54, Postoperative Infections of the Spine. Key concepts from this chapter include the management of surgical site infections in the setting of spine surgery. Surgical site infections are frequently encountered and cause significant morbidity and can place an enormous financial burden on the healthcare system and patients. The most important thing is early identification and treatment of postoperative infection, and it's key for minimizing morbidity and potential mortality. Patient-level risk factors for postoperative spine infections include increasing age, obesity, diabetes, poor nutritional status, and alcohol and tobacco use. Additional factors to consider include chronic steroid usage, rheumatoid disease, and an immunocompromised state. An important management consideration is that treatment methods for early onset wound infections and late onset implant infections can differ. In early onset wound infections, the spinal implants may provide stability, but in late onset infection, fusion or arthrodesis may have occurred and hardware removal may be indicated and appropriate. In the setting of infection, interbody cages may be kept in place if there are no signs of loosening. Unless infection persists, there is no role for one-stage exchange of hardware. Loose bone graft should be removed, however, but structural graft may be kept in place. There is no consensus strategy employed to combat inadvertent contamination during spine surgery. The use of perioperative antibiotics, antibiotic-containing irrigation solution, and intraoperative antibiotic powder are all modifiable surgical risk factors that can be used to minimize postoperative infections of the spine. Surgical site infections, or SSIs, are the most frequently encountered hospital-acquired infections. Over 500,000 surgical site infections occur annually and account for well over $10 billion of U.S. healthcare expenditure. Therefore, routes to prevent infection, facilitate early diagnosis, and provide adequate treatment are of significant interest. Surgical site infection following spinal intervention occurs in 1 to 5.5% of patients, and there are certain high-risk patients and populations that occurs more commonly in, and these include spinal trauma patients and patients that carry malignancy. For non-instrumented spinal procedures, for example, a lumbar discectomy, the infection rate is quite low, less than 1%. Superficial infection in this setting may present within 1 to 2 weeks. The avascular nature of the intervertebral disc predisposes it to infection. This may manifest several weeks to months following intervention and can be found to have less virulent organisms, most notably Cutibacterium acnes, formerly known as Propionibacterium acnes. Erythrocyte sedimentation rate, or ESR, or C-reactive protein, or CRP, may be elevated early on, and in later stages, radiographic changes within the disc and end plates may occur. In patients that undergo larger lumbar operations, such as a laminectomy without fusion, there's approximately a 2% infection rate. Laminoplasty, either performed in the cervical, thoracic, or lumbar spine, is associated with slightly higher infection rates, likely secondary to increased length of the procedure. As one can imagine, non-instrumented posterior spinal fusion operations have a higher rate of infection than decompressive procedures alone. This is a result of longer operating times, greater blood loss, greater soft tissue destruction, and the placement of devascularized graft. Posterior cervical single-level decompression with foraminotomy carries a very low infection rate, which nears less than 1% in the literature. A multi-level cervical posterior decompression, which is a larger operation, carries nearly a 2% rate of infection. For anterior procedures that are strictly decompressive or with or without instrumentation have a very low rate of infection. The use of instrumentation increases the incidence of postoperative infection from approximately 3 to 7%. The reason being is that hardware acts as a site for secondary seeding rather than a source of inoculation. Most infections can occur in the acute period, but it is not uncommon to see infection several years after surgery due to subsequent biofilm formation, which may offer delaying and protective effects. Historically used steel implants carry a greater predisposition to colonization and delayed spinal infection. However, newer titanium implants are resistant to corrosion and have a greater resistance to colonization. In general, anterior instrumented spinal surgery has lower rates of infection, and if they do occur, they tend to be superficially located. The highest rates of infection alternatively come from combined anterior-posterior approaches, and this is likely from greater length and complexity of cases. Minimally invasive techniques have been recently pioneered and escalated in their indications and complexity, and they minimize soft tissue trauma, blood loss, and recovery. Mueller's group recently demonstrated a 7-fold reduction in surgical site infections in comparing minimally invasive surgery to open surgery, and an overall 10-fold reduction in surgical site infection for decompressive operations. We know there are certain risk factors for surgical site infection. These can be either patient-specific risk factors, disease-specific risk factors, or surgical procedure-related factors, of which we will go over in the next few sections. Patient-specific factors that may predispose to surgical site infections include increasing age, obesity, which can lead to longer operative times, greater retraction forces, diabetes mellitus. It is known that surgical site infection can occur in up to 1/4 of patients that suffer from diabetes. Poor nutritional status, really defined as a serum albumin of less than 3.5 or a total lymphocyte count of less than 1,500. Chronic alcohol and tobacco use, steroid use, rheumatoid disease, and an immunocompromised state. Surgical factors that may predispose or raise the concern for infection include the number of levels treated, with a longer length of surgery being at higher risk, longer surgical operation time or duration of surgery. The cutoff for this measure is typically approximately 5 hours, places patients at higher risk for suffering surgical site infections. Along with this goes increasing procedural complexity and increased bleeding or amount of blood loss, which if it exceeds greater than 1 liter. Additional surgical risk factors include revision surgery, use of allograft material, and surgery extending to the sacrum or pelvis. Disease-specific factors that may predispose to infection include malignancy, spinal injury suffered in the setting of trauma, and prolonged pre-surgical hospitalization and postoperative stay in the intensive care unit. Blom et al. Reported patients staying in the ICU for more than 1 day had anywhere from a 6 to 13-fold greater risk of postoperative infection than those patients that did not have an ICU stay. Clinical findings for surgical site infections of the spine can be variable. They can be confined to the superficial space, which is defined as above the fascia, and these patients can present with erythema, purulent discharge, local tenderness, and separation or dehiscence of the wound edges. They can also have a low-grade fever, and laboratory evaluation may reveal an elevated erythrocyte sedimentation rate, C-reactive protein, and white blood cell count. Deep infection, which is defined as infection below the level of the fascia, can be more variable in their presentation. They can present acutely 2 to 3 weeks after surgery or several months to years thereafter. acute presentation may carry significant pain, fever, anorexia, and night sweats. Evaluation of patients being worked up for surgical site infections of the spine include a thorough physical examination and neurological examination, laboratory evaluation with a white blood cell count, ESR, CRP, gram stain, and culture if there's an open wound. Radiographic studies are often obtained and may range from plain radiographs, which may demonstrate disc space narrowing, bony destruction, blurring of the end plates acutely, and vertebral body collapse and sclerosis of the end plates chronically. Computed tomography or CT imaging may demonstrate similar changes as plain X-rays, but give an improved sense of anatomic delineation. In addition, this may help with planning procedures such as a CT-guided biopsy, and the addition of myelography, which should be used carefully in the setting of suspected infection, may implicate epidural or subdural infection as well. Nuclear medicine studies, the use of technetium-99 bone scans may have limited sensitivity and specificity, and FDG positron emission tomography testing may represent a future opportunity. The use of magnetic resonance imaging, or MRIs, carries a very high sensitivity and specificity for diagnosing infection and osteomyelitis. You may see hypointensity on T1 imaging or T2 imaging, with hyperintensity seen on T1 post-contrast with avid contrast enhancement seen in the area of suspected infection. From a bacteriologic standpoint, skin flora are the most common causative organism in postoperative surgical site infections of the spine. This includes staphylococcal species, in particular Staphylococcus aureus. Methicillin-resistant Staphylococcus aureus occurs with enough frequency that antibiotics should be held until adequate cultures are obtained. Recent studies have demonstrated that Staph aureus is the most common organism that is identified from spinal surgical site infections at 45%, followed by skin flora and less virulent organism Staphylococcus epidermidis, which occurs at 31%, and then gram-negative organisms at 30%. Isolation of Cutibacterium acnes, or formerly known as Propionibacterium acnes, may take up to 1 week's time. Thus, culture should be followed out at least to this length. Non-operative treatment for surgical site infections may be initially tried and employed in certain cases. This initially starts with local wound care and antibiotics. Postoperative discitis may be treated non-operatively, and pathogens may be obtained from blood cultures, which are positive in up to 50% of cases. Broad-spectrum antibiotics are initiated and narrowed based on culture data. If no causative organism is found, then anti-staphylococcal coverage should be utilized given the high likelihood that this may be the culprit. A typical course for non-operative treatment or in the setting of operative treatment includes IV antibiotics for 6 weeks, followed by an oral course of antibiotics for 6 weeks. This would also take careful surveillance with blood markers including ESR, CRP. It should be noted that infectious disease specialty expertise should be sought on cases where there is concern for management or treatment of infection. Surgical treatment of surgical site infection is the more common element of treatment that is employed, specifically for wounds that have broken down, have purulent discharge, or fluctuants with concern for deep extension. These require operative exploration with the primary goals of number 1, diagnosis of the infectious agent or pathogen, number 2, debridement of non-viable tissue, and number 3, assurance of stabilization. Treatment methods for early onset wound infections and late onset implant infections can differ. Here we outline a management of spinal surgical site infection algorithm. If there's initially a concern for a surgical site infection, then a thorough physical and neurological examination, imaging with either X-rays, CT, or MRI with contrast, and serum blood testing to obtain ESR, CRP, and a white blood cell count with differential. If there's a high suspicion for infection, if it's non-instrumented, then subsequently wound and culture swab should be obtained and either a biopsy. If there's evidence of superficial infection, you should consider debridement. Deep infection, you should also consider debridement if medical therapy is not able to eradicate or control the infection. In the setting of instrumentation, is it early infection? If it is, the idea should be to preserve hardware to ensure that there's spinal instability. If it's a delayed infection, CT scan should be obtained to ascertain whether or not there's evidence of mature bony fusion. If there's no fusion, then all attempts should be made to preserve the hardware. If there is evidence of fusion and instability is not a concern, then consideration of hardware removal should be undertaken. Treatment of infections in the setting of intrathecal pain or drug pump and spinal cord stimulators can be very challenging. These typically involve removal of the device and initial treatment with broad-spectrum antibiotics, with narrowing as cultures allow. With both spinal cord stimulation and intrathecal pump, either with pain medication or with baclofen, there is a concern that there would either be drug withdrawal in the setting of the medication-eluting pump or recrudescence of severe pain in the setting of a spinal cord stimulator. Both of these considerations should be managed very carefully. Techniques and surgical adjuncts in the management of spinal infections after surgery include the use of a wound vac or wound vacuum assisted closure, an irrigation suction technique, and in additional cases, the use of antibiotic beads, which can deliver a significant local concentration of antibiotics to the area in the setting of both superficial and deep infection, and rotational muscle flaps if there's not adequate vascularized tissue coverage to ensure proper healing. If rotational muscle flaps are employed, consultation with a plastic surgeon is recommended. The most important aspect of surgical site infection management of the spine is prevention. There are certain preoperative and intraoperative factors that we can use to help mitigate the risk of infection. Specific preoperative factors include smoking cessation, optimizing nutritional status, treatment of concomitant infections, urinary tract infection, upper respiratory infection, avoid unnecessary removal of excessive hair unless it is in direct barrier to the surgical site, and if it does need to be removed, it should be done so with clippers rather than razors to prevent microabrasions and possible seeding of skin flora, and the use of prophylactic antibiotics. Most typically used as a first-generation cephalosporin, which is cefazolin. If patients are MRSA positive or allergic to cephalosporins, then vancomycin may be used. And in the setting of a vancomycin allergy and a cephalosporin allergy, then clindamycin may be used. Intraoperative factors including maintaining a strict aseptic technique in field. Double glove technique has been shown to reduce the amount of infection. Intraoperative irrigation of the wound, and potential employment of vancomycin powder.